So, thank you for this amazing presentation about hypnotase. Actually, I want to present you the need for cryo. At first, we want to run through a little bit of the anatomy. Facet joints are true zonable joints with a hyaline cartilage and a joint capsule and even kind of a meniscate. You can see it here and right there. The innovation is through a dual supply from a medial branch, which arises directly from the dorsal ramus, and expect the facet joint L5. There, the dorsal ramus innervates the joint directly. On this picture, you can see the radiation of the pain throughout the facet joints. That's maybe come because of large numbers of nociceptive and autonomic nerve fibers, substance P, or also inflammatory mediators which have been found in active joints. So this is the same idea as you have shown. Now we want to have a look for the intervention. Here's the possibility to do diagnostic intervention when you want to treat the facet joint pain further. You have to do a medial branch block. It's a two-level block. You recommend to do with lidocaine or bupivacaine. It should be pain relief from at least 50% to maybe 80 or 100. It differs. Even for the number of blocks, there are a lot of studies which did single-level blocks. They are proposing a high false positive rate when you do a single block. Other studies recommend to do it a double or even a third repeated block, and for the second block, preferably with another local anesthesia. Steroid injections we will do with long-acting steroids. You can do it intra-articular, peri-articular, or as a medial branch. There are no differences between intra and peri-articular, and the European guidelines even did recommend the intra-articular steroids, and it's not suitable to derive the positive reactions through injections for an indication for RF. So the chemical neurolysis use phenol and alcohol, which leads to protein denaturation. Maybe the block lasts 3 to 6 months, but major drawbacks, for example, necrosis, neuritis, and it's maybe not uncommon. The physical neurolysis, which I want to talk about, have two players, the cryo and the radiofrequency. Both are ending in the cellular denaturation. The cryo uses the rapid decompression of gas, which concludes leads to an ice ball on a conduction block at minus 20 degrees, and getting a long-term pain relief through the vascular damage. By the radiofrequency, an ionic agitation gets to friction and tissue heating, which leads to irreversible cellular denaturation about 45 degrees. There are a lot of different aspects, even for the temperature. For the duration, there are a lot of studies they're doing at 60 seconds, 90 seconds, 120 seconds, pulse radiofrequency, maybe for a pulsed circle for 30 seconds. So you have a very, very bright range, even for the size, for the probes. For the radiofrequency, it's very important to do it parallel to the target nerve. For the cryo, it's not essential. The probe lesion by the cryo is circumferential, by the radiofrequency transverse. The tip lesion is big by the cryo and little by the RF. When you look for the literature, you have a high study rates about the radiofrequency, which almost leads for 60% pain decrease at 12 months. The cryo is not even so popular and not even so well studied. As in the literature has shown, we have a pain decrease maybe for 50% at 6 weeks and at 6 months. The probe size here differs from 12 to 14 G by the RF, which I've shown from 18 to 22. Even in Germany, the guidelines didn't recommend the cryo. Last month, a new guideline for the radiofrequency is published only for the RF in Germany because maybe of this less popular outcome of the studies. There are no actually published studies which compare the cryo against the radiofrequency. I found a new article which compared the cryo versus pulse, but it's a Mexican group, it's only in Spanish, and they all have a population by 8. And there's another study from a working group from Aarhus in Denmark. They are still recruiting. Yeah, so that's what it's right now. My experience with the cryo is in my old department in Marl. This is a hospital and the area of Dortmund. There we do approximately 500 cryos a year. Our subject relief of symptoms was that most patients have a relief of about 6 to 9 months. We use the cryo with a 12G, with a 7 millimeter active tip for 120 seconds and by a temperature of minus 70 degrees. So therefore I had the idea to running a comparative study called EFFECT. It's a RCT, single center and single blinded, performed at Marl Hospital, Department of Orthopaedic Surgery. We started recruiting in May 2020, and we had a lot of eligibility and exclusion criteria. I want to point out the NRS under over 6 under physical exertion and the NRS reduction over 80% after the medial branch blocks, which maybe is very high rated. We had 2 interventions arms, 1 year follow-up. Follow-up was conducted over telephone. We went the study through the COVID lockdown. Primary outcome is the NRS scale. Secondary is a questionnaire, oswestry and Roland Morris, even on analgesic intake and opiate intake. The definition for us for the response or for the positive response was the pain-free, good results and moderate results at the follow-up at 6 weeks. We had 94 patients included for the recruitment, excluding 9 after the medial branch. So we had 86 left, 45 for cryo, 41 for radiofrequency. The technical data for the cryo is the same as we used. For radiofrequency, we used the LG2 lesion generator from Inamed, the C3 crystal from Inamed, and the size for the probe is 20G with a 7 millimeter active tip, 120 seconds by a temperature of 80 plus degree. So NS at rest shows an increasing of the pain level under 3, which we want to achieve. And maybe with the decreasing until the 6 months and increasing after 12 months again. The NS under physical exertion shows similar results with the decreasing of the pain level under 3, most under 3 until the 6 months, and then increasing after 12 months. When you look for the results measured by treatment success by the NS under rest, we have already good results for the cryo, almost good results for the radiofrequency. Even at the 12 months we have moderate results. Under physical exertion, the cryo seems to be much better because we have good results for 6 weeks, 3 months and 6 months, and moderate after 12 months. The cryo, so the radiofrequency differs a little bit. 6 weeks was good, 3 months moderate, 6 months really good, and 12 months moderate. We had a high dropout rate. That's not so good, but when you look for the dropout, we had a lot of patients which are both pain-free or had good results when they left. The improvement of the life quality was better until the 6 months. There were a little bit differences between the cryo and the RF, even for the Roland and Morris. For the analgesic intake, when we have a combined NSAIDs plus non-opiates, you will see a decreasing of the intake. For the opiate intake, there are no big difference for the low potency, for example, tramadol or tilidine. For the high opiates, for the high potency, we will show, or we have shown, a good decreasing for the combined non-opioid with high opioids with the combination of NSAIDs plus non-opioids and high potency opioids. And we also saw an increasing of patients who don't need any analgesics after the treatment. So the discussion, the cryo showed good results at rest for the whole time, for the physical exertion until the 6 months. This is what confirms and maybe exceeds previous results. For the cryo, we also, for the radiofrequency, we also have good results for the under rest until the 6 months, and for the physical exertion at 6 weeks and 6 months. And this is not confirmed, the previous results, because there was a pain decrease at 12 months for 60% of the patients. But we all achieved the NLS under 3 in the NLS under or at rest by the NLS under physical exertion for the radiofrequency only at week 6, and for the cryo at the 6 months. The secondary outcome, there were a total of 6 months improvement for the reduction of the analgesics or opioids. There was a high reduction for the high potency and combined intakes, and a strong reduction of the NSA and non-opioids. When we compare it, it seems to be no big difference between the NAS at rest or changes for the mobility and life quality. They have all the same good results in reducing the need for analgesics after 12 months. But differences were seen at the NAS under physical exertion. These are the limits of our study. We had no placebo group. We had no fixed follow-up. Our patients get an instruction letter after the dismissal. We have difference between the size of the probes. Probably there are some problems with the technical handling of the ERF probe, and we had a high dropout rate. So I want to conclude. We have to know the anatomic aspects of the fascioid joints. We have to need or to do a diagnostic medial branch Ambrock. The cryo and the ERF is a physical neurus, causes cellular degeneration. The ERF is well studied with good long-term results. The cryo may underrepresent. The effect showed good results for cryo and ERF as expected, but better long-term results for cryo as not expected. And so maybe the cryo is not be inferior to the ERF as treatment for lumbar facet joint pain. So that's for me. If you have any requests for the literature, you can ask me. I can send you it by email, or you can make from the homepage. So thank you very much.